اللي راح نحكي عنه اليوم هو part of the curriculum for the fourth year medical students in neurosurgery, clinical neurosurgery. It is focused about neurosurgical physiology and the neurocritical care management, which is a subspecialty in neurosurgery, neurocritical care, and it is a subspecialty in anesthesia. يعني في ناس منكم اللي راح يروحوا anesthesia في يوم من الأيام ممكن يسووا neurocritical care، أو حتى ال ICU intensivist بعد ما يخلص medicine ممكن برضه يسوي neurocritical care، لأنه في special circumstances, special considerations للنeurosurgical patient، سواء كانوا neurological أو neurosurgical patient. There are special consideration in the management. So this is why it is important, and it is very common that you will see patients with a neurosurgical condition, especially in emergency department, especially with head injury patient, spine injury patient. And the management in the emergency department or A&E will determine the outcome most of the time. It is very important that the ABCs are done correctly. It is very important to manage these patients from the outset as a neurosurgical patient, with giving consideration to the neurosurgical physiology and the neurocritical care management. On this lecture, we won't be able to cover, of course, all these topics. There's too many topics under this heading. So we will just give you a teaser about the most important parts of the neurophysiological care of patients. We'll start by a case presentation. So this is a 45-year-old male patient. He's known to have mitral valve replacement, which was done 10 years ago. He presented to E&E with decreased level of consciousness, left-sided hemiplegia, and he's febrile, neutrophilic, with elevated CRP. He underwent echocardiogram, which showed mitral valve vegetation. First, risk factors. From the history, he had MVR, which is mitral valve replacement. And as you know, these can be either mechanical or metallic valve replacement or biological. And they can get infected. And when they get infected, they make embolic, infective emboli that goes into the circulation. And given the history of fever, neutrophilia, and the elevated CRP, it is most likely that this patient is having infective endocarditis. And with showering of the emboli, he ended by having left-sided hemiplegia and decreased level of consciousness. So he underwent a CT scan, and on his CT scan, you can see that there is an area of infarction. It's involving the majority of the parietal lobe, area of basal ganglia, and extending posteriorly. And this area is the hypodense area here, is an area of infarction. And this is what we call the distribution of the middle cerebral artery. If you remember from your anatomy, the carotid artery, the internal carotid artery, will bifurcate and give two branches. The first one is the anterior cerebral artery, which supplies this area and goes backward along the corpus callosum. Sorry. And the other one is the middle cerebral artery, which will supply the temporal lobe, massive part of the frontal lobe, and extends posteriorly to the parietal lobe. So what is this hyperdense area here? This is what we call ICP monitor, or intracranial pressure monitor. This was implanted to measure the intracranial pressure, which we will talk about today, what we mean about it and how we manage it and how we monitor it. So how you will treat this patient? Of course, we need to treat the underlying pathology, which is the infective endocarditis, by giving him IV antibiotics according to the culture. And you may consider embolectomy, which is removal of the embolus, or thrombolysis, which is destruction of the embolus by anticoagulant medication. And the other thing which is important for us as a neurosurgeon is to prevent further brain injury. So there is area of infarction. Surrounding the area of infarction, there will be what we call penumbra. And this area of penumbra is ischemic. So if we can maintain a good hemostasis or a good stasis around the brain, and we keep nourishing the brain with oxygen and glucose, then this area will be salvageable and the patient may regain some of the function from the penumbra. The other thing about this, that this infarction will worsen, or not the infarction, the edema surrounding the infarction will worsen over the next few days. And if this edema worsens, then this will may cause increase in the intracranial pressure, which may cause further problems for these patients. And we will come to talk about these complications of intracranial pressure later. So our priority is to keep, as neurosurgeons in this situation, is to keep the brain well nourished with oxygen and glucose. And what vehicle that transmit the glucose and the oxygen is blood. And here where the term cerebral blood flow comes. So we need to prevent further injury by maintaining adequate oxygenation, maintain metabolite like glucose, and wash out with like CO2. And this is maintained by maintaining cerebral blood flow and decreasing demand. So what we mean by decreasing demand? So the brain itself uses about 15% of the cardiac output and extracts a large amount of oxygen from the blood. So if we can decrease the demand of the blood, of the brain to oxygen by sedation, by anxiolysis, by even full anesthesia, then this may help to protect the brain against ischemia and infarction. Let's focus now on maintaining the cerebral blood flow, which is the amount of blood per second of the time, or the volume of the blood per second of time that reaches the brain per 100 kilogram of tissue. And in the original study, the mean volume was 65 ml per 100 gram. There is a big difference between what the cortex consumption of water, or the flow of, of blood consumption of the cortex to the blood compared to the white matter. The cortex will have the more blood flow compared to the white matter, and we will come to these numbers in the next few slides. So what is it? What is the cerebral blood flow? As you know, to drive any flow, you need a difference in a pressure, and this comes from Ohm's law. If you remember this from your physics, it is the difference in the voltage divided on the resistance, or the فرق الفولتية مقسم على المقاومة عشان نعرف الكرنت or التيار بالعربي. Cerebral blood perfusion pressure is the difference in the pressure between the arterial pressure and the venous pressure. The venous pressure is almost always equal to the intracranial pressure. Sometimes it is slightly higher in normal physiological condition, not pathological condition. It is slightly the ICB is slightly higher than the venous pressure is slightly higher than the intracranial pressure by 2 to 3 millimeters mercury. So what is the CBP? Then, because it's the difference between the arterial and the venous pressure, then it is the MAP, which is the mean arterial pressure, minus the intracranial pressure, or as I said, the venous pressure, which is almost always equivalent to the venous pressure. So هنا في اسمه cerebral autoregulation واللي هو within certain limit, okay, of cerebral perfusion pressure, the brain can regulate the amount of blood volume that flows inside it. وبالتالي إذا ارتفع أو هو بين 60 ملم mercury cerebral perfusion pressure و 160 ملم mercury cerebral perfusion pressure, the brain will be able to regulate the diameter of the blood vessels, okay? وبالتالي it will decrease the blood volume or maintain it around 55, okay? Which is this plateau here, okay? Anything below this will cause ischemia. Anything over this will cause impaired of the autoregulation and may cause hyperemia, expansion of hematoma, and expansion of the contusion. So how this happens, there are different mechanisms. Some of them are mechanical, and these are related to the stretch receptors or mechanoreceptors within the walls of the blood vessels. There are theories about what we call a neurogenic control of the blood vessels, and this is related to the presence of the astrocytes surrounding the blood-brain barrier, and they secrete some neurotransmitters that will affect the diameter of the blood vessels. And there's another theory about the endothelium of the blood vessels synthesizing some materials like nitrous oxide, eicosanoid, and prostaglandins, which will affect the diameter of the blood vessel. And between this plateau, the cerebral perfusion will be maintained. Sorry, the blood volume or the blood flow will be maintained, whether the changes of the cerebral perfusion between 60 and 160 millimeter. So when we go back to the first scenario, this patient has a cerebral perfusion pressure of 70. And thus, if it is 70, it is within the autoregulation and the patient should be fine. Okay, or at least he will be fine from the point of view of cerebral perfusion pressure and cerebral blood volume. If we have the look at the second scenario, this patient is likely to have ischemia. Okay, and probably if it continues towards this or his ICB goes up, he may end by having infarction. And the only thing that I can manipulate in this formula here, if the ICB is constant, is increasing his mean arterial pressure by giving him vasopressors, giving him IV fluid. On this situation, I have to reduce it because I cannot allow it to be higher than the autoregulation level. Keeping in mind and that in head injury, infarction, the autoregulation is impaired to a certain limit. It is not working as in normal situation. And the other scenario or problem with the autoregulation that is based in patients with, let's say, hypertension, who are used for increased blood pressure, they will have a higher level of autoregulation for MAB. So their CPP may be autoregulated between 70 and 170 because they are hypertension patients. It's not similar to patients with no hypertension. So we need to keep this in mind when we're treating these patients. The thing that you didn't ask about it is the CVR, which is the cerebral vascular resistance. The cerebral vascular resistance is a very difficult to manipulate because any changes in the diameter of the blood vessels will affect the cerebral perfusion pressure, and it will affect the viscosity of the blood. And it is difficult to measure the cerebral vascular resistance. So what we depend on almost all the time is the cerebral blood flow and its relation with cerebral perfusion pressure. We'll come and explain the relation of the viscosity and the length and the resistance in a second. But I want you to keep in mind that the cerebral blood flow is not equal to the cerebral perfusion pressure. It is the cerebral perfusion pressure divided on the cerebral vascular resistance. Okay, let's see what happens if the blood pressure is constant, but the ICB is variable. So this patient has 170 blood pressure, but his ICB is 5. If I apply this for the cerebral perfusion pressure, his CBP will be 75. While if his ICB is pathological and it is 35 due to this increase in the cytotoxic edema surrounding this area of infarction, his CBP will be 45. And in this situation, I have two options. Either I increase the MAP or I treat his increase in intracranial pressure. And there are different methods to treat the intracranial pressure, and we will come and to discuss it towards the end of this seminar today. So let's go back and see what is the cerebral vascular resistance. So if we assume that these are two blood vessels, they have the same length, and the length of the blood vessels is the same. You cannot manipulate it. You cannot change the length. Okay, so we consider it as a constant in considering the formulas for CPF or for the resistance. So the resistance equals 8 by L, which is the length of the blood vessel. So we consider this constant. So you grow up, you have small length of blood vessels. The more you grow up, you will have a longer cerebral blood vessels. But after a certain age or after maturity, you will have a fixed length of blood vessels. This is divided on pi or multiplied by the radius of the blood vessel to the power of 4. And this is important because any change on this is going to be significantly reflected on the resistance because it is to the power of 4. So if we say that there is a reduction of about 50% on the blood vessel, diameter. So if it is 4 and now it is 2, this means there's a 16-fold increase in the decrease in the resistance. Okay, so the radius of the blood vessel is the main determinant for the resistance for the cerebral blood flow. Let's see what's happening here. This is a small diameter blood vessel compared to this one. So I assume by definition that the resistance in this one coming from first the friction of the RBCs, the plasma, the components of the blood with the wall of the blood vessel, and the friction of the component of the blood itself with each other. This will have a higher resistance. And if it is having a higher resistance, it means that the cerebral blood flow will be much lower. If we look at this one, this is a larger blood vessel, and there's more space for the components of the blood to flow. And when they flow through this, the resistance is less, and this means the cerebral blood flow is more. Okay, so what is making this difference? What is the main chemical transmitter gas that will make this change in the wall of the blood vessels or the diameter of the blood vessels? This is the BCO2. Okay. There are other factors like the nitrous oxide, like the oxygen, and BCO2. The partial pressure of CO2 is not directly the cause, so not the CO2 that increases the blood vessel. And there's lots of theory. The most acceptable one is that the BCO2 will increase the acidosis around the blood vessel, and this will cause the vessels to dilate. And it is very potent vessel dilator. Okay, if we see the increase of on this curve here, slight increase in the BCO2, and this is the cerebral perfusion pressure here, the cerebral blood flow, we can see that it can be maintained at a certain level, and then the vessels will dilate very, very quickly. And this is a dilemma in a neurosurgery, because if you dilate the vessels too much, it means that you are increasing the blood inside the skull. And if there's increase in the blood inside the skull, it means you are increasing the intracranial pressure. At the same time, you want to maintain the cerebral blood flow. And that's why we try to keep the BCO2 within normal limit, which is BCO2 between 35 and 45. The only times that we use what we call hyperventilation, seeking the BCO2 between 32 and 35, not less than that, is to reduce the amount of the blood entering into the intracranial cavity and making the vessels smaller. And we use this just for momentary control of blood pressure, of intracranial pressure. You cannot use this for a long time, because if you maintain the blood vessels, the low BCO2, you may end by having ischemia of the brain. And this is one of the problems, that this was a common practice previously. When I was a resident, it was a common practice, and we used to drive the BCO2 below 30 to 28. This is our target. And actually, most of our patients ended by ischemia, and they died, especially the patients with head injury. And this method is difficult now to change, or this old practice is difficult to change. So you need to know that there's nothing anymore called hyperventilation. We don't drive the BCO2 below 32. And if we do it between 32 and 35, we are just doing it because there's no other way to reduce this blood intracranial pressure momentarily. We need to do it quickly, and we have to do it now. And this is the only way we can have it. So we do hyperventilation to BCO2 between 32 and 35, but not lower than that. And you will find lots of problems, even in reviewing the literature on finding the ideal BCO2. For the sake of exams, we just say normal capnia, BCO2 between 35 and 45. Because as you noticed, if I make it smaller, I may cause decrease in the cerebral blood flow and ischemia. If I make it larger, there will be more blood going inside the brain, and this blood will cause increased intracranial pressure, as we will see in what we call the Monro doctrine, the Monro-Kelly doctrine in a second. So the other thing is the cerebral metabolic rate of oxygen, the amount that the brain uses from oxygen. The brain uses about 3.8 mil per 100 milligrams. And this is the about an average 55.2 mil per minute for somebody with a brain that weighs about 1.5. What I can do to decrease the metabolic pressure rate, so I protect the brain from going into ischemia and going into infarction. First, prevent seizures. Seizure is a metabolic event. It will require lots of oxygen. And the absence of this oxygen will cause cascades of infarction, ischemia, and failure, cell swelling, which will worsen the ischemia and the edema. So prevent seizure. Patients with head injury should receive, if they have a moderate to severe head injury, they should receive anti-epileptic prophylaxis, at least for the first 1 week after injury. Treat fever. If these patients are febrile, they need to have their temperature brought down. Control blood sugar. And last thing, one of the measures that you can use to reduce intracranial pressure is to reduce the demand by sedation, and you need to be careful with the anesthetic drugs because some of them will lower the cerebral blood volume, some of them will increase the ICP like halothane. Sevoflurane will improve the cerebral perfusion pressure and reduce the metabolic rate of the brain. So these are the two things. You have a demand and you have the offer. You need to maintain the offer to a level, okay, which is adequate for brain to oxygenate. And if you have having problems with the offer, you cannot maintain the cerebral blood volume flow, you have to reduce the demand by putting the patient, by doing these measures and putting the patient to sleep and anesthetize him in severe brain edema. So don't worry about this schedule, it is easy, okay? If you remember that so CO2 elevation and decrease in CO2 level, so they will be opposite to each other, okay? So increasing the CO2 will increase the diameters. This will decrease the resistance, and thus the flow will increase. If cerebral perfusion pressure decreases, this means that the diameter of the blood vessels has increased, the resistance will decrease, and thus the flow will increase. If we look at the temperature, okay, it means there's more demand because the temperature is there, so the blood vessels will dilate, and thus the resistance will become less and the flow will increase. But increasing the flow, okay, is not always possible to couple it with the demand. And this is why we need to treat high temperature. So this is the difference. Usually the minimum blood flow that there's one concept I just want to let you know about it, that when we talk about cerebral blood flow, there's the global cerebral blood flow, which the one we can actually manipulate. And there is the regional blood flow, which is changing according if there's insult, there's injury, or there's brain activity. And this is one of the principles of the functional MRI scan. They put you in the MRI scan, they ask you to do some tasks, and these tasks like speak. And when you are speaking, they will notice that there will be increase in the blood flow towards the vernix and the Broca's areas, or doing certain activities like moving your hand. And this regional blood flow is difficult because you cannot control it, and it is important to avoid certain pathologies like regional ischemia, but you cannot really manipulate the parameters for regional blood flow till now. We don't know if in the future we can see something like this. However, if we maintain the blood flow to any part of the brain, so whether it is the gray matter or the white matter, and remember the gray matter requires, because the cell bodies are there, will require more blood and more oxygen compared to the white matter, which is just the fibers and the tracts of the neurons. If you maintain it between 45 to 60, that would be enough. Below 20, you start to get ischemia. At 12, the brainstem is very resistant to decrease in the cerebral blood flow, but below 12, you start to see some changes, and actually you are going towards brain death, which happens when you have a cerebral blood flow below 10. Is 3 components or 4. Okay, I like to call it 3. في عندي the brain tissue. This is the first one. Okay, وحكينا the average brain tissue is 1.2 kilograms to 1.5. We have CSF, which is about 75 mils in the ventricles and subarachnoid spaces. And we have the volume of the blood, which is almost the same amount of CSF. So the Monro-Kelly doctrine says this is a closed box. The skull is a closed box. They assume that the skull is a closed box. And if the volume of one of these 3 components, the blood, the brain, or the CSF, increases, it will be on the expense of another component. What does this mean? If there is a mass inside the brain, and this is its volume, this volume will replace some of the other volumes to have a space for it. So there will be CSF will be drained to the outside, or venous blood will be pushed into the sinuses and into the jugular vein. So any increase in the size will be on the expense of another part of the brain. At certain point, you may reach that the mass will displace even the brain tissue and later even stop the arterial flow into the brain. Okay, the more the mass increase, the less capacitance or compensation the brain will be able to do. So at the first, the patient may have no symptoms and his ICB will remain the same because the brain sends CSF to the outside, CSF to the outside, or venous blood to the outside, and this is compensated for the size of the mass. عشان هيك ما صارش في عندي increase في ICB. زاد الماس أكثر من هيك. Okay, ما فيش عندي more reserve. There is no more reserve to drain CSF. There is no more reserve to drain more venous blood. And this will result in increase in the intracranial pressure. If it goes uncontrolled or the mass is not removed, then the brain tissue will start also herniating and going through the foramens of the skull. And we will talk about the herniation symptoms later. باختصار السكال عبارة عن صندوق مغلق توسع حجم ثابت. أي زيادة على هذا الحجم راح تكون على حساب حجم آخر. الحجم اللي في الأحجام اللي في الأول بيقدر الدماغ يتخلص منها CSF والفينس بلد بيخلص من جزء منهم. بس بعد فترة they cannot tolerate هاي الأماونت. They cannot drain more CSF. The brain cannot drain more venous blood. وهذا راح ينتج عنه ارتفاع في ضغط الدماغ أو increase في intracranial pressure. Okay. So what is the intracranial pressure? It is the pressure within the cranial vault, and it is relative to the atmospheric pressure. Normal ICB and the adults 10 to 15. Children 3 to 7, infants 1.5 to 6, and the neonate it is in the minus, which is -2. But there's non-pathological, and keep this in your mind, non-pathological increase in the ICB. Like what? If I sneeze, if I cough, there will be a momentary increase in my ICB, and it can reach 40 and 50 millimeter mercury. But this is momentarily for seconds, and then it will go back down. Constipation, straining, all of these can increase the intracranial pressure above 15, but it is not pathological because it is usually momentarily and related to specific circumstances. Usually, we start to consider the ICB as pathological when it is sustained above 20, and this is when we start to treat, because between 15 and 20, we think the brain can compensate. After that, it will start to fail on compensation. So again, the brain compensates. We consider that the brain essentially is non-compressible, so an increase in the volume and the inside the skull will decrease either the CSF or the cerebral venous pressure. CSF primary displays to the spinal subarachnoid spaces. The blood, there will be vasoconstriction, and the blood will be displaced into the jugular venous system. Failure, exhaustion of the compensation, then there is a limit for this hemostatic mechanism. Once we exceed this level of compensation, then we start to have increase in the intracranial pressure, and this will bring us to this curve. Okay, intracranial volume, intracranial pressure initially, there is a mass growing inside the skull, and there is a good compensation happening here, and the intracranial pressure is maintained. Then we start to lose our reserve to maintain this intracranial pressure. The CSF has most of it escaped to the outside, and the similar happened to the venous blood. So we start to get more and more pressure going up till we reach this degree where there is a complete failure of the compensatory mechanisms, and there's a rapid increase in the intracranial pressure. And this rapid increase in the intracranial pressure will replace the brain tissue itself. It will compress the arterial blood vessels and cause ischemia. And this herniation and ischemia will go into a cycle of still swelling, cytotoxic edema, further increase in the intracranial pressure, and it will ultimately end by death. Again, if we have it looking at this as a volume, intracranial pressure, compensation, CBB will be reduced, and there will be increase in the herniation risk after the failure of the compensatory mechanism. لحد هون خلصنا الفسيولوجي. راح أبلش أحكي عن المننجيز. We'll talk about in the anatomy of the intracranial compartments is the meninges. And as you know, the meninges are the covering of the brain. There are three layers. We have the dura mater, we have the arachnoid mater, and we have the pia mater. The closest one to the brain is the pia mater, and the furthermost, or the outermost one, is the dura, and we have the arachnoid. It's important to remember that in the cranium, the dura mater is two parts: meningeal dura and periosteal dura. In the spine, we lose the periosteal dura and we have only meningeal dura. Why this is important? Let's have a look at this illustration here. So we have the skull, the scalp, the skull, and then we have the meninges. The meninges, as I said, the dura, the outermost layer. It is actually two layers. One which we call the periosteal layer, and the other one is the meningeal dura, or the dura proper. These ones do fuse together with age, and they are not separated from each other except in certain places, like areas of the sinuses. So let's look at the superior sagittal sinus here, and you can see that the periosteal layer has separated from the meningeal layer to form the sinus. And then the two opposing meningeal layers fuse together again to make the falx cerebri. The other place where these, we will see that there's the falx, there's the tentorium, and the rest of the sinuses are places where the two layers of the dura are separated from each other. One interesting thing is the middle meningeal artery, which comes from the maxillary. It's a branch of the maxillary artery, which is the branch of the external carotid artery, and it comes through foramen spinosum, and it runs on the outer surface of the periosteal layer. And that's why when there is bleeding, it will be in the epidural space. When we have injury to the middle meningeal artery, it will be in the epidural space, and this will result in extradural or epidural hematoma, and this will be the topic on next Sunday. The other issue is that because this is a periosteal layer, if you remember from the embryology, that there will be sutures. We have the sagittal, we have the coronal, we have the lambdoid sutures. And this periosteal layer will be enclosing the bone from the outside and the inside. And this enclosure will result that the periosteal layer is separated from the meningeal layer. But this will create a tough attachment for the whole dura to the sutures. And this is why when you get epidural hematoma, it will be limited most of the time to the sutures. So it does not, epidural hematoma does not cross the sutures. The second, let's go back. So the second layer is the arachnoid. Okay. It's the one in the layer, in red. And the main characteristic of this one is that the blood vessels that supply the brain and the veins, and the veins that drain the brain runs in this subarachnoid space, except when these veins cross the dura to drain into the sinuses. And this is what we call the bridging veins. And this is important because if we get a rupture of these bridging veins, there will be bleeding in the subdural space. And this is the cause of most of the time of subdural bleeding is rupture of the bridging vein. And sometimes it can be laceration to the brain tissue and bleeding into the subdural space. The other thing about the arachnoid, if you get pathology on the arteries like aneurysms, they rupture, the bleeding will be in the subarachnoid space. It will not be in the subdural space. Okay, so when we get a rupture aneurysm, you get it in the subarachnoid space because these arteries run in the subarachnoid spaces. When you get a rupture of a bridging vein, you get a subdural bleeding because these veins are crossing the subdural space. They leave the arachnoid into the sinuses, and this is why they result in subdural bleeding. The last layer is the pia mater, which is attached closely to the surface of the brain. And through these layers or the sulci, we have the capillaries running through, and there is the astroglial endothelial membranes, which is part of the blood-brain barrier. So again, so we have this is the pia mater. We have the astrocyte here. And then we have the pia mater. It's a single layer of a flattened cell. In between, we have what we call the arachnoid granulations, and these actually fibroblasts, which made these arachnoid trabeculae. And remember also that one other characteristic of the subarachnoid space that we have the CSF within the arachnoid space. We have the arachnoid trabeculae, which is sustaining these blood vessels in this space and holding them tight. The blood vessels are all running, whether it is artery or vein, in the subarachnoid spaces. And then we have the arachnoid mater here, and these are the dural vessels. What happens to the pia mater in the spine? There's two things. The pia mater in the spine will be condensed in the midline, on the lateral aspect, and these on the lateral aspect will run towards the dura and form what we call the denticulate ligament or the dentate ligament. And this is part of the system holding the spine in place while we are moving. And it is exactly between the dorsal rami and the ventral rami. If you can see here, so it runs between the ventral root and the dorsal root, and it's also attached to the dura. What happens toward the end? If you remember from your anatomy that the termination of the spinal cord is called the conus medullaris, and the green layer here is what we call the filum terminale interna, which means this is a condensation of the arachnoid, which forms the filum terminale. And because there's two filum terminales, and this is a very usually untypical, unknown information for most of the doctors, filum terminale interna is the one inside the dura, and then we have the dura itself, which condense to form the filum terminale externa, which is attached to the sacrum. So this one is in continuation with the filum terminale externa. Arachnoid, it's the same image, and we have explained most of it actually. So I'll move again to the dura mater. Just want to confirm that you understand these two things. The dura is two layers. The periosteal meninges, and the other one is the meningeal layer or the meningeal dura, meningeal or the proper meninges. They usually fuse to each other, and this they are separated only around the sinuses. Around the sutures, when these suture line unite and diffuse together, you will get the dura adherent. Don't look at this one because this is a sagittal suture, but let's assume that this is coronal and it is here. Okay, both layers of the dura will become very adherent to the suture, and this is why when there's bleeding in the epidural space, it will not be able to strip the attachment of the dura from the sutures, and this is why the epidural bleeding is limited to the suture line. So what is the value of having all these duras? Let's look here. So the dural fold will make something called the tent, and this is here is the tent, which separates the supratentorial base. Anything above this area is called supratentorial. Anything below it will be called infratentorial, and this is at the level of the midbrain. Let's look at this one. Why it is the midbrain? It has the cerebral peduncles here. It has the black thing is the substantia nigra in both sides. The tent is attached anteriorly to the anterior crinoid process and making what we call the tentorial incisura. This is the optic nerve coming through the optic foramen, carotid artery. This is the pituitary, and this is the basilar artery here, and this is posterior cerebral artery. If you imagine that the temporal lobe will be sitting here, and the most medial part of the temporal lobe is called the uncus, and we will speak about the uncal herniation soon. So the uncus will be around here. When it moves medially, it will compress the third cranial nerve. So if there's hematoma on the temporal area, and it pushes the temporal lobe medially, the first part of the temporal lobe will be the uncus, will be exerting some pressure effect on the oculomotor nerve, and this will result in dilated pupil. Further progression will compress the crus cerebri or the cerebral peduncle, and this will result in contralateral hemiparesis or hemiplegia. Again, this is another view. This is the occipital lobes, and you can see the falx cerebri here, the straight sinus, which is a fold of dura, and it is draining blood to the trochlea, making the lateral or the transverse sinuses. And here is the tent. It really looks like a tent. It is not flat like we imagine it sometimes. It is not flat. It is like a tent coming from superior to the inferior. If we look at the infratentorial compartment, these are the transverse sinuses or the lateral sinuses. And this is the falx cerebelli, which is a fold of the dura that separates both cerebellar hemispheres from each other. And this is the C1 and the level of the foramen magnum. In the supratentorial space, as I said, this is the tent here. And as I said, it is like a tent because this is coming this way down here to the temporal fossa. Supratentorially, we have the falx cerebelli, which separates the cerebral hemispheres into right and left cerebral hemisphere. Reviewing some anatomy, this is the corpus callosum, and this is the anterior cerebral artery, which will divide, giving the pericallosal artery, which also divides and gives the callosomarginal artery. This will continue to go backward, and at a certain stage, it will supply the medial part of the motor cortex. And if we get infarction in this part, if you remember, the medial part of the motor cortex from the homonuclear is responsible for innervation of the lower limb, and thus this will result in weakness in the lower limb if we get ischemia due to compression. So what happens if there's a large hematoma compressing the right cerebral hemisphere? It will be pushing all the cerebral hemisphere against this falx to a degree that this cingulate gyrus will herniate across the falx, causing what we call subfalcine herniation. And this, if it is severe enough, it will cause compression on the callosomarginal artery, which may cause ischemia in the motor cortex. And we will speak about these herniation syndromes soon. The arachnoid matter, again, I cannot focus enough. It is the anatomy. If you understand the anatomy, you can tell why everything happens and the physiology. This is an aneurysm in the subarachnoid space. You get this rupture, you get blood in the subarachnoid spaces. Rarely, if this arachnoid, very rarely, arachnoid layer is deficient, you may get subdural bleeding. And certain times you get intraventricular and intracerebral hemorrhage, but most of the time it is the subarachnoid. So any place with subarachnoid space, which is usually filled with CSF, you will see it bright because the acute blood is bright on a CT scan. So we can see these are the sulci. Usually we should see them dark. Here is the basal cisterns, which is part of the arachnoid layer. It's filled with hyperacute blood. This is the temporal horns of the ventricles, and this is the fourth ventricle.
Okay.
I'm going to repeat this. Bridging vein crossing from the subarachnoid space to the sinus because of a trauma, because of aging and the brain atrophy. You get rupture of this vein, and this will result in a massive subdural hematoma. Usually, if it is acute blood, or if it is acute blood, it is hyperdense on the CT scan, and it is eccentric on shape, and it is not limited to the sutures, okay? And we can see the midline shift here. Again, if it is extradural, it's different. We get usually from injury to the middle meningeal artery. We can see that at this suture limit, which is the sequamous sutures, the dura cannot strip because of the severe attachment or the strong attachment to the dura, similar on the sagittal sutures, and we get extradural or epidural hemorrhage, which is convex in shape. This is again acute epidural hematoma with convex shape, and it is limited to the sutures anteriorly and posteriorly. What are the causes that may cause increase in the intracranial pressure؟ زي ما حكينا في في المونرو كيلي دكتراين انه احنا في عندنا 3 components. في عندي blood، في عندي CSF، وفي عندي brain tissue وديورا. اي شيء راح يزيد البرين تيشيو، اي شيء راح يزيد البلد، او اي شيء راح يزيد CSF may cause increase in the intracranial pressure. ايش ممكن يزيد البرين تيشيو؟ tumors، brain edema، واللي هي 3 انواع، يعني cytotoxic، طبعا هم 5 انواع بس the most important ones are cytotoxic edema, vasogenic edema, and interstitial edema. We'll talk about these in details in the next few slides. A tumor itself can cause increase. So increase in the tissue itself may cause the increase in the intracranial pressure. The tumor sometimes can have hemorrhage, and this will be the blood within the tumor causing the increase in the intracranial pressure. Sometimes the tumor, or most of the time, the tumors have some kind of vasogenic edema surrounding them, and this vasogenic edema can result in the increase in the intracranial pressure. Blood, it can be bleeding, like subdural, epidural, subarachnoid hemorrhage, intracerebral hemorrhage, intraventricular hemorrhage. And then we have the CSF, which can cause hydrocephalus, whether it is non-communicating, communicating, or due to increased production. All of these can result in increased ICP. Sometimes the tumor can cause hydrocephalus, like in non-communicating hydrocephalus, and this may result in increased intracranial pressure. Let's have a look. So let's start by hydrocephalus. In this one, we have a hyperdense lesion in this area, which is the foramen of Monro. These are the lateral ventricles. These are the frontal horns of the lateral ventricles. This is the occipital horns. And this is the third ventricle, and this is the foramen of Monro around here. These colloid cysts, or this lesion is called colloid cyst, and it usually happens in the foramen of Monro, and it causes obstruction of the flow, and this will result in obstructive or non-communicating hydrocephalus. We get communicating hydrocephalus, so there's the supratentorial part of the ventricular system is dilated, as well as the infratentorial part. This is the fourth ventricle. These are the cerebral peduncle. This is the rest of the cerebellum. This is the temporal horns of the lateral ventricles, and this is the pons here. And we can see all the ventricular system is dilated, and this is what we call communicating hydrocephalus, and typically we see this in meningitis. Very rare is the increased production of CSF, which have in choroid plexus papillomas. This is the papilloma, it's a tumor, or carcinoma, and these can produce more than the usual CSF, and thus this may result in hydrocephalus. Blood, as we said, subarachnoid blood in the subarachnoid spaces. It can be subdural, it's eccentric in shape. It is not limited by suture, so it is subdural. This one is typical extradural, limited by sutures, convex in shape, or it can be contusions, multiple brain contusions. And these are surrounded, these hypodensity, the hyperdensity is blood, the hypodensity is edema. These hypodensities are edema surrounding this blood, and both of them together can result in increased ICP. Brain tumors can be this is an olfactory groove meningioma, and this can result in an increase in the intracranial pressure by itself. Or this tumor, which is a high-grade glioblastoma multiforme, had a bleeding inside it, and it is surrounded by a massive edema, which both together resulted in increased intracranial pressure. This is a metastatic lesion from a lung cancer, and you can see how the vasogenic edema, how large it is. All this hypodensity around the tumor is a vasogenic edema, and this is participating in the increase in the intracranial pressure. So what are these three types? I keep saying vasogenic, cytotoxic, and interstitial. Let's start by the easy one. You get hydrocephalus. There's increased pressure here over the ependymal cells. This will cause hydrostatic pressure on the ependyma and make the fluid filtrate into the brain tissue, and these will be the hypodensities here causing the interstitial edema. So it is usually edema due to hydrostatic pressure from hydrocephalus. Cytotoxic edema. So all the cells, including the nervous cells, astrocytes, the blood vessels, the endothelium, are swollen. And this swelling results on this appearance of hypodensity involving the white matter and the gray matter. And we see this typically in ischemia. So this is an ischemic changes in the distribution of the anterior cerebral artery and the middle cerebral artery. And this is where the involvement both the gray matter and white matter. If we look to this one, the vasogenic edema, it is due to disruption of the blood-brain barrier. So this is a tumor here. Okay, this is disrupting the blood-brain barrier. So there is a leak of ultrafiltrates and the proteins and the fluids to the brain tissue, and this results in this kind of edema. If you can notice here, it is mainly involving the white matter tract, but it is preserving the cortex, the gray matter, and this is very typical for vasogenic edema. So again, this is tight junction, this is endothelium, these are astrocytes, and these are tight junction, and this is the plasma inside. We don't have leakage from here in the normal capillary. What happens in vasogenic edema, there will be increase in the distance between the tight junction, and the plasma filtrate will escape into the intercellular spaces, causing the hypodensities that we've just seen on the CT scan. While in cytotoxic edema, there's all the cells are not working properly, including the astrocytes, the neurons, and the endothelial cells, and this causes them all to be swollen. And once they are swollen, they are not working well, and all the tissue, we will start to have apoptosis and death of these cells and release of excited mediators, and this will result in diffuse edema involving both the white matter and the gray matter. So how a patient with increased intracranial pressure may present to you. First, there's a difference between how quick the patient developed increased intracranial pressure. The quicker the ICP increases, the more severe the symptoms. So let's talk about a patient who just suddenly developed subdural hematoma or extradural hematoma after a trauma. They usually present with rapid deterioration on the level of consciousness. And this is because the compensatory mechanisms has been exhausted very quickly. While if we are talking about, if you remember the image that we've just seen, the olfactory groove meningioma, this has been growing for a while. It is massive in size, but the patient presented with signs and symptoms related to the compression of the brain tissue rather than symptoms related to the increase in the intracranial pressure, because this has been going up slowly over time and give time for the compensatory mechanisms to work. But generally, there will be change on the level of consciousness when there's increase in the level of and the intracranial pressure. Usually starts with agitation, confusion, and restlessness. If it progresses, it may progress to decline in the level of consciousness and finally to a coma. There will be decrease in the Glasgow Coma Scale, headache, nausea, and vomiting. So the typical vomiting of increased intracranial pressure, usually called projectile vomiting. And this is the definition that we like for this, is vomiting without nausea. So the patient suddenly, without any alarming sign, will vomit. And this is why we call it projectile. It is not because it is being pushed far away from the patient. It is just because it is not preceded by nausea. If it is preceded by nausea, the patient will be alerted that he's going to vomit, so he takes his precautions, while in this one, it just happens, and that's why it looks like it is projectile. Then there will be gradual pupillary changes may happen, if there's compression on the third cranial nerve due to ankle herniation, this may cause dilatation of the pupil. And these progress, as you discussed on Sunday with Dr. Salem, for motor postures, decortication, decerebration, and then we may get fixed non-dilated pupils, irregular respiration, cardiac arrhythmias, and lastly, which is a very late manifestation of severe brain edema, which is the Cushing triad, which is a systolic hypertension with bradycardia and irregular respiration. So let's look at these type of herniation syndromes, because this is another possibility. The patient may present with herniation syndromes. We have this acute subdural hematoma causing compression on the brain tissue. This is an acute one, so it is rapidly progressing. This patient came unconscious to the emergency department. This is the fault, and usually it appears the hypertension on the CT scan, and you can see that the area of the cingulate gyrus has been pushed under the edge of the falx cerebrally to the contralateral side. This is the left-sided ventricle. It's completely pushed by this subdural hematoma, and this patient has a subfalcine hematoma. And if this was not evacuated, most likely this patient would have developed infarction on the cingulate artery, on the cingulate artery or pericallosal artery distribution, resulting in weakness in his lower limb. While this one is a tumor that has been growing for a while, and this is the falx. This is an MRI scan, T1 with contrast, and you can see this is the corpus callosum. It's been pushed underneath the falx. Just because this has been growing slowly, this patient presented with very mild symptoms of confusion and difficulties in cognitive function. Another one, we call it the ankle herniation. If you remember from the anatomical views, that this is the temporal lobe. This is what we call the uncus of the temporal lobe. And because of this tumor been slowly growing, it is compressing the uncus. anchor, sorry, is compressing the cerebral peduncle, and this patient presented with left-sided, because this is the right side, and this is above the level of decussation, which happens in the medulla. He presented with left-sided hemiparesis and unilaterally dilated pupil. On the other side, on this CT scan, this is again another acute subdural hematoma, which is very common, causing midline shifting. This is where the midbrain should be, and the ANCAS has compressed the midbrain, the middle cerebral, the third cranial nerve, and the patient has unilaterally fixed dilated pupil at the presentation and right-sided hemiplegia. The third and the last type of herniation that there's different, the herniation syndromes can be up to 5, some box write them, some box write 6. The important ones are 3, the ankle herniation, the subfalcine herniation, and the tonsillar herniation. And in this one, this is the tonsillar herniation. This is a sagittal T2 MRI scan. You can see that this is the clivus, which is part of the occipital bone communicated with the sphenoid. And here is the pituitary, or the sella turcica, where the pituitary gland sits. This is the midbrain. This is the pons. This is the medulla. And the cerebellum is around here. If you notice that the medulla is at the level of C1, C2. This is the C2 vertebrae, which is abnormal. The foramen magnum level should be around here. So we have herniation of the posterior, or sorry, the inferior part of the cerebellum, which we call the tonsil, through the foramen magnum. And this is because of the congenital abnormalities in the cranio-cervical junction. This patient presented with symptoms related to the cervical myelopathy rather than symptoms related to the herniation of the tonsils, because this has been going on for years and years before she presented to us. While this patient has a post-CBR patient who was found on community, and this is the foramen magnum. And you can see, usually you should see some CSF around here, but you can see the foramen magnum is crowded and it is full of brain tissue. And the reason for this is that because of the massive cerebral edema, the tonsils herniated through the foramen magnum, and this was very quick event. This patient had compression on the respiratory centers and died with respiratory arrest. So it is always different how acute the herniation symptoms develop and what type of herniation symptom, the herniation syndromes the patient developed. Is it subfalcine, transtentorial, or ankle, or it was tonsillar herniation? So we spoke about, this is how the patient presents. It is either the symptoms of the global increase in the intracranial pressure, or localized where the lesion causing compression, or he presents with one of these herniation symptoms. So how I can treat to this, I need to first to monitor this intracranial pressure. There's multiple ways to know the intracranial pressure. As we said, there's invasive procedures and there's non-invasive procedures. The indications for intracranial pressure here, these indications for invasive intracranial pressure monitoring. The non-invasive, like a CT scan, MRI scan, optic disc examination, Doppler ultrasound, tympanometry, all of these are non-invasive, and you can do them as part of your workup if they are available quickly, like a tympanometer is not available easily. Once you diagnose a high or increased intracranial pressure with a surgical cause, you will not wait for optic disc examination. You will just take the patient to a theater. But if the patient is not surgical yet, okay, and you want to do invasive intracranial pressure monitoring, these are the recommendations. All patients who can have surgery or salvageable patients with GCS of 3 to 8. And when we say salvageable death, we mean patients who are not brain dead, and they have abnormality on the CT scan, and this is level 2 evidence. This will improve the outcome. Level 3 evidence, any patient with severe head injury with a normal scan, if he's above 40, has a motor posturing like decortication, decerebration, or has a systolic blood pressure below 90. So how we can monitor ICP? Invasive, EVD, external ventricular drain, and this is the gold standard. We have micro transducers ICP, we have fiber optic, we have a strain gauge, and we have the pneumatic. We have the non-invasive like transcranial Doppler, tympanic membrane displacement, optic nerve sheath diameter, magnetic resonance images, and CT scan and pupillometry. These are the main ways of ICP monitoring technique. The lower ones, the non-invasive, cannot give you number. The top ones we would give you readings. Okay. As a location, we can have the ICP monitors within the ventricle. We can have them within the parenchyma of the brain. We can have them in the subdural space. We can have them in the epidural space. So it is different, and it differs according to the design, the company, what you are planning to measure. Some of these will have like EVD. This is the EVD, external ventricular drain. So it is inside the ventricle, goes through the skull. You can get measurements from the ventricle, and at the same time, you can drain CSF as a therapeutic measure. And this is the external ventricular drain. So we can zero it and put it at the level of external auditory meatus, and it is used to drain CSF from the mid ventricle. And at the same time, it is giving us very accurate measurement. The problem is it can cause hemorrhage, infection, occlusion, malposition. All of these complications do happen, and the worst one of them is actually infection and ventriculitis. We have the microsensors. So these are the Codman company. We have this microchip we implant in the parenchymal, intraparenchymal spaces, intraparenchymal tissue, and it will give us readings. But the problem with these ones are not therapeutic, so we cannot drain CSF or anything with them. They just measure the ICP. Well, they're not just the ICP. Some of them even can measure the level of the PCO2, PO2, the level of the glutamate, which is excitatory neurotransmitter, and this is part of research rather than treatment, the measurement of the neurotransmitters. Spielberg, which is the one I've used most. These one have a balloon inside at the end, and this balloon, this machine will keep inflating this balloon, and with a sensor inside the balloon, they will also measure give you readings on this machine, the Spielberg machine. Some types of them have this small opening at the tip, and you can drain CSF from it. But from experience, most of the time it is useless because it gets obstructed and it does not work. So we discussed now the causes of the ICP. We discussed how we can measure it and the importance of measuring the ICP and the treatment. Lastly, how we can treat the ICP. This is from your textbook, elevate the head of the bed 30 degrees, and this is to improve the venous drainage and lowering the ICP. You have to remove any neck collars, especially in our hospital. We don't have fixation devices for the endotracheal tube, so they will put some gauze around the neck and they will tighten it, and you will come and you will see that both jugulars are compressed for this patient, for your patient, and this will increase the intracranial pressure. Always in the ER, look out for these two things, because these are the quickest things to do in the emergency room. And as a GP, elevate the head 30 degrees and put the neck straight in the neutral position. Because as the patient's head is tilted to one side, they will cause obstruction to the venous output, and this will cause further increase in the intracranial pressure. Treat fever, and this will decrease the CMRO2 and lower the ICP. Maintain normocapnia, not hypernatremia. normal. Okay, the only indication for hyperventilation or hypocapnia, very mild hypocapnia in emergency situation, but nothing other than that, please, and not below 32 millimeters. We don't use this anymore. The other thing is you can sedate your patient with propofol, fentanyl, and midazolam, and this will decrease the consumption of O2 and thus lower the CT. Always try to treat the cause. The ICB, increased ICB, is actually a symptom of an underlying pathology. You try to treat the pathology. When there's a cause like a hematoma, you have to treat it. When there's a brain tumor, you have to treat it, and this will really definitely reduce the patient ICB. Then drainage of CSF may help if it is possible. And the other thing that you have to control all the electrolytes, not only sodium, because all the electrolytes will play a role in the cytotoxic and vasogenic edema. So tight control of these in addition to tight control of the blood sugar. Then we can use hypertonic saline and mannitol, and we'll come to these in a second. Mannitol. The mannitol is, as you know, is a osmotic diuretic, and this will pull the water from the cerebral hemisphere, from the interstitial spaces and the extracellular spaces into the blood vessels, and this the water will follow the mannitol, and this will be excreted by the kidney. The problem with it, you need to hydrate the patient very well. It can cause renal injury. The other thing, you cannot use it for a long time. We used to use it regularly, and now we just use it on a stat order. So just if there's increase in the intracranial pressure, signs of herniation, we give mannitol. Other than this, we rarely use it regularly in treatment of intracranial pressure. The other thing is the hypertonic normal saline. It is almost similar mechanism of action. You have lots of sodium inside the blood vessels because of this hypertonic saline, and this will cause the water to shift from the outside to the intravascular component, and this will reduce the vein edema. The last thing is surgical treatment of massive or refractory intracranial pressure, and this is a surgical treatment we call the compressive craniotomy. It is ugly surgery. I doubt that any of the surgeons like it. As you can see, you just remove a big chunk of bone, and then all the brain will herniate to the outside instead of going through the tenotorium or the foramen magnum and causing further problems